Welcome to GW Integrative Medicine, the podcast about disease prevention and health promotion from the Office of Integrative Medicine and Health at the George Washington University School of Medicine and Health Sciences.
I'm your co-host, Dr. Lee Frame, an Associate Professor of Clinical Research and Leadership in the GW School of Medicine and Health Sciences, Director of GW Integrative Medicine Programs, and the Office's Executive Director.
And I'm your co-host, Janet Rodriguez, the Office's Administrative Director. Today we're going to talk about proton pump inhibitors, or PPIs, their risks. Specifically, we're going to focus in a little bit on dementia. And our guest today is somebody who's familiar to the pod, Dr. Misha Kogan, who's the Medical Director of the GW Center of Integrative Medicine and an Associate Professor of Medicine here at GW.
An expert on neurodegenerative diseases, Dr. Kogan completed the Geriatric Fellowship at GW. He is the chief editor of the first definitive textbook on integrative medicine and aging, Integrative Geriatric Medicine, part of Andrew Weil Integrative Medicine Library Series.
Welcome back to GW Integrative Medicine, Misha. For those of you who are new to the pod, he's also one of our co-hosts.
So, long time no see, everybody. I missed you. It's great to be back.
Likewise. So, Misha, what are proton pump inhibitors, or PPIs?
Right. So, it's probably one of the most prescribed classes of medications, at least in the United States. I'm not sure about the rest of the world, but it's definitely a very popular class. It dates back many decades, and particularly before this class, we had acid suppressant medications that used to be affecting more of a histaminergic pathway, and those were not very effective. When the PPIs, let's keep calling them short, PPIs, came on market, it was kind of revolutionized the entire gastrointestinal field because it started treating a lot of different problems, not just acid reflux, which is intuitive, right? The acid reflux is often triggered by elevated acid, so suppressing acid makes sense. But also things like gastritis and peptic ulcers, and in essence, within the scope of just few years, definitely became one of the largest, one of the most prescribed drug, not just in gastroenterology, but in the entire, out of all the classes of medications. And the frequency of use gotten to a point where several PPIs got approved for over-the-counter use. So you can literally walk into any pharmacy in the United States and buy them without any prescription. People generally often take them for very mild symptoms of any kind of discomfort in the stomach. And so the number of doses of this medications taken in a country is exuberant. It's hard to be precise because, again, prescriptions are no longer being written for many of them since people just buy them over the counter. So back in around 2010, the data started coming out suggesting that PPIs are, especially prolonged use of PPI, tends to change the gut microbiome. So this is a topic that's very close to Dr. Frame's heart, and I think we're going to touch up on this multiple times, particularly when I think we're going to start talking about dementia. And so that concern gradually has been becoming more and more clear. At this point, we even have some particular suggestions as to which microorganism go down, which ones go up. Patients who take a lot of PPI or chronically use PPIs. And the problem is that not only this medication is prescribed, nowadays people can obtain them over the counter, and that leads to a kind of an uncontrolled, very frequent intake, and not just for particularly approved conditions such as, let's say, peptic ulcer disease, but also for just a very mild shifts in acid. I think periodic acid reflux is a normal thing pretty much if it comes and goes, but people tend to now take this medications literally as candy, so it's really hard to estimate exact proportion of people taking them. And since we have this increasing concerns of long-term use of these medications leading to a whole bunch of side effects, which we'll talk in a second, I think we decided to do this podcast as just to give our listeners a lot more details on this, and not just as a cautionary tale, but just as an understanding of what these medications can do as a whole.
Yeah, I agree. There's a lot to unpack with this topic. This is not a simple, straightforward topic where we're going to just zoom in on one or two studies. It makes it pretty difficult to cover, but I think we're going to do a good job here. We've want to focus first on what are some of the latest studies in PPI, because there was something that just came out recently about dementia and PPIs, and I think that's one we really need to address today.
Yeah, so this specific potential association between prolonged use of PPIs and risk of dementia has been on and off for many years. I think the first I started noticing this somewhere around 2015, the first suggestive link. It was a lot of back and forth. I think there's still a lot of back and forth, but I think, Dr. Frame, you're particularly talking about this study that came out in October this year in Neurology, which is a very respected journal, linking a very large database of patients taking PPI to a quite significant risk of dementia. For full disclosure, even this article has been heavily critiqued, and of course, there's a since this medication is so widely used, everybody's taking this quite seriously. Nobody's taking this lightly. But I think the advantage of this particular study was that they, instead of doing what's often done, looking back at the data and simply saying, okay, if we take cohort of patients who are taking these medications and when we take cohort of patients who are not taking medications, we go back, look how long they took it, and compare those two arms. The problem with that is that retrospective analysis always has biases that could end up causing the association that's not real. So versus in this study, it was the reverse. So the patients were looked forward. So they took over 5,000 dementia-free participants, and they were following up for more than 5 years, and then they sort of divided them into those who were using PPI and those who were not. So this prospective study, in some ways, is much more significant because it's expected to have less biases and be more accurate. And there was quite a significant increase. There was a 33% increased risk of dementia during this time of follow-up. And the important point is there's a way of statistically analyzing the data, and what's called a confidence interval of 95% was between 1 and 1.8. So the highest number was 80%, and the lowest was just at no risk. But cumulative average risk of 33%, I would call that very significant. And despite the fact that, again, even this study was critiqued, this is probably currently the best study we have, at least as it relates to population in this country. This was the US study, by the way.
So one of the things that stands out to me, particularly in light of some recent studies on multivitamins and cognition, is part of this mechanism of action could be that the decrease in acid reduces the absorption of nutrition, which potentially could increase your risk of cognition. Is that where you're thinking this is predominantly coming from, or is there something else that's more of a primary mechanism of action?
I don't think we know. I think it's probably multifactorial. I have no doubt that sort of something nutritional plays an important role here. And we're not just talking about B12, which is very commonly discussed, right? The B12, a lot of people quite familiar with, and they take extra doses of possibly bypassing this risk. But this relates to a lot of other nutrients, some other B vitamins, minerals, even potentially some fatty acids. I think the other big point is I just started talking earlier that there's a change in microbiome. And, we know that the microbiome seems to have a very strong relation to risk of dementia. Now, what we don't know is what is that exact relationship and how do you fix it? In fact, as we're talking about, we are running a study here at GW trying to assess this exact link. So it could be that, it could be nutritional, or it could be something that we don't even know. So I have not seen an attempt to unpack this, to actually take a clinical study and look at specifics of the risk. The risk between shift in microbiome and PPIs has been studied heavily. And then there has been studies done between risk of shift in microbiome and risk of dementia. But then, exactly what's happening here, I think will take longer to unpack. So Unfortunately, I don't think we know exactly, but we suggestive risks are multiple. So in microbiome and potential shifted nutrients. It's also interesting the fact that if you drop the production of acid, you're not just changing, microbiome and nutritional absorption. You're shifting entire function of the gut. And so with that, what else are we possibly missing? We're missing the way digestive enzymes begin to operate. If you change acidity, enzymes often become less efficient at breaking down some of the parts of the food that goes down. And I'm just giving some examples. We do know that peristalsis changes, meaning how the bowels continuously squeeze all the food and then waste products all the way down. So all of the function changes. Now, within that, which pieces are the ones that seem to be the one increasing risk of dementia? I don't think we know for fact, but we can, as I said, suggestively think of those things that I mentioned.
So one of the things you'd mentioned previously is that this is for treating, overly zealous acid-producing guts, people whose guts are overly producing acid. But that's what we're talking about when we're talking about a prescription. People who are taking this over the counter may not actually have excessive production of acid. Are we more concerned about PPI use in those people?
I think, honestly, just my opinion, on the record here, I'm concerned of all use. In fact, even when they prescribe for something like chronic acid reflux or even ulcers, the problem is often it is not because of the high acidity. In fact, a lot of the digestive dysfunction, I would say, relates to other problems. It's not all about acid. In fact, we know for a fact that often there is a lower acidity, and we have seen a lot of side effects from these medications acutely. The patient will call me and say, so they put me on this pill and now I feel a lot worse. So this happens, I don't know what exact frequency, but it happens all the time. And so the problem is, back in the day, I would say 10, 15, 20 years ago, we used to measure pH before prescribing these pills. It was a common practice back in the day. And I think because the perceived safety of these pills and the fact that measuring pH you had to kind of drop the probe all the way down to the stomach. It was an extra step and it wasn't all that easy to do. It kind of fell out of favor. And in the last few years, I haven't seen anybody doing this test, which is, I think, very unfortunate, because often patients are prescribed these medications without having any clue whether or not the acidity is high or low. I've heard some really smart gastroenterologists say something along the lines of, well, we don't care whether the pH is increasing or decreasing, so we don't care what the acidity is, as long as we're leveling acidity. So we just kind of block spikes that patients get better. So basically, it's not the pH per se, it's the lack of ups and downs, so to speak, that's becoming more therapeutic. So there was one way to explain that. In that sense, then what is exact pH when you start treatment doesn't matter. But it's pretty clear to me that patients who complain about immediate side effects, they somehow has to be different from people whom PPIs benefit right away. So with that in mind, it looks like that basically you just kind of can't use them as a best pill for everybody. It clearly doesn't work, yet that's what we do because it's seemingly common practice. I know I'm kind of went on a rant here, but
No, it's absolutely common practice because it's easy to do within the time that is allotted in our modern healthcare system, to try and figure out why this individual person with their individual microbiome and individual lifestyle are intermittently having peaks in acid is very complicated, and it's probably going to take multiple visits, multiple testing, and more than a 15-minute visit to really even get any information. And so this is why that's not being done.
Exactly. That's exactly the reason. It's impractical to try to figure it out, especially when, as I said, anybody can respond positively, and you just don't know whether you can truly tease out quality of response by doing additional tests.
So why is the dementia PPI connection so controversial?
Well, that's a great question. I am not sure. I think the early studies have been all over the place because they would take this large observational cohorts, manipulate the data, and see that the risk potentially disappears. I think the biggest problem, whenever you're looking at the risk of dementia, you have to do a very long studies. So, doing a study for 1 year is going to be useless because, you're looking at some risks that may take 5, 10, 20 years to manifest. So it becomes expensive and also very complex, right? Because if let's say you have to run a study for 10 years, I mean, that's a huge commitment, right? I mean, I'm not even just talking about finances here. I'm talking about just the overall complexity of follow-up. People can disappear for all kinds of reasons out of studies that are completely unrelated to what you're looking at, right? I mean, you can get hit by a car and get eliminated from the study and you'll never have an answer. So whenever the study is very long, your confounders, so the facts that potentially going to alter the results unrelated to what you're looking at, are going to increase simply by just living life. And I think that's part of the problem. I mean, the risk here, it doesn't seem to be super strong. It's not like, let's say, if we look at other medications, for example, benzodiazepines or drugs that block acetylcholinergic effect in the brain, the impact there is much faster. But with PPIs, that increase in risk is very slow and it's cumulative, and that's also very clear. So if somebody listening to this and they're like, oh my God, I took omeprazole yesterday, so I'm going to have dementia tomorrow. No, you won't. Don't worry about it. In order for this to occur, you'll need to take that omeprazole for many years continuously. So if somebody is taking it intermittently, I think the risk is going to be very small, if any. But the bigger issue is, let's say this risk is absolutely true. And let's say that it is linked not just to dietary shifts or to a shift in absorption and assimilation of some particular nutrients, but it is linked to microbiome, which is what I believe. I actually think that the stronger link is to microbiome, not just to the nutrients. And if that's the case, and everybody takes these pills, what are we doing in the long run? So let me position where I'm going with this. So there's been a data some years ago saying that even a couple of doses of these drugs tend to change the microbiome. Now, that change seems to be small and often reversible, but you're taking these pills again and again, and we have a very high percent of entire population do so from very young age. I mean, these pills are often given to kids, even not teenager, to children, little children, because the medication is perceived relatively safe for all ages, right? So with that in mind, what are we doing long term for the entire population? What's going to happen with, say, 10 or 15 years from now when cumulative intake of these pills in the entire population gradually increases? Is this explaining a potential increase in longitudinal amount of dementia cases out there? Who knows, right? I mean, we don't have all answers to this, but it's a provocative question that researchers have to ask to try to answer. Because if it is, then we need to be more cautious with these pills.
The thing that comes to mind for me, especially with what you just said about children, is, sometimes this acid reflux is connected to food allergies, right?
Absolutely.
So I'll tell you, I'm gluten intolerant, and I know when I've accidentally, had some gluten, because that's pretty much the only thing that gives me acid reflux. And so when I stay away from it, guess what? No acid reflux. So I can't help but think how many of these children and adults have turned to this pill when really they may have an undiagnosed food allergy.
Well, that's a golden statement, which you just described. I think that's a big part of the problem, that often these pills are used as a kind of a band-aid to a real problem that's not being addressed. And so, when you have a symptom, the body responds to try to answer the symptom, try to figure out what's happening. But if you band-aid it and now there is no symptom, now where's the incentive to try to solve the problem? So you're 100% right. That's surprisingly, I kind of look at this class of medications slightly different through my integrative geriatrics lens to look at this like this. They are exceedingly safe for a short period of time. So the people who would complain from side effects taking these drugs are generally very mild. They may just, the acid reflux may not resolve. They may feel it actually sometimes gets worse with those pills. But the reality is that those side effects are generally very mild and serious side effects are not known. But that's in the short run. In the long run, these pills appear to have universal risk of side effects, meaning every person who takes them eventually will have side effect. And that is completely not discussed. Like, when is the last time a prescriber of this pill will tell the patient, oh, and by the way, in 5 years, you're going to have 10 times higher risk of Clostridium difficile infection? Nobody talks about this. And that's the problem. The problem is that these pills are very safe in the short run and very unsafe in the long run. And what is that long run? Well, it's not clear. Are you going to get that side effect of severe colitis from infection a month from now or 10 years from now? And that's a big difference. And there's no easy way to answer that. And by the way, it's not just US. We're talking about the entire world. I've reviewed recently a study in Korea showing exactly same link of PPI to high risk in Alzheimer's disease. And actually in Korea, that risk was much higher. They're looking at the risk of almost doubling it in certain situations, although when they adjusted all of the other COVID variants in the study, the risk was 36%. So it was kind of close to the 33% in this most recent study. So we know that it's not just us here in US, right? It's a worldwide phenomenon.
One of the things that stands out to me about this is yes, what you're saying, but also the variety of long-term side effects that are popping up. For instance, cardiovascular disease or kidney stones. They're very broad and varied in terms of their mechanism, unless perhaps the common mechanism is actually by way of the gut microbiome and either a gut-brain axis or a gut-skin axis or a gut-immune axis that is then affecting things downstream.
That's what I think. I mean, it's not, I don't think we can prove it, right? I don't think we can say that we have something that we can support our statements outside just the common sense and the data that's showing that this change in microbiome. But taking that next step is a bit harder. So I do think you were right, though, that impaired absorption of nutrients also plays a big role. I'm pretty sure of that.
Yeah, this is probably multifactorial, which is all the more reason it's difficult for us to figure out because there are these multiple causes and multiple mechanisms. And then that you combine that with the nascent stage of the gut microbiome field where it's, we don't even really have great understanding of what a dementia microbiome looks like, let alone how PPI might contribute to shifting a microbiome to be more pro-dementia.
Yep. So I have this study that was published in 21 in Curious, which is a good journal, that basically kind of looks at all of the combined adverse effect profile. And they have this great photo there, like the figure that basically shows almost every organ in the body is negatively impacted in the long run. We're not just talking about the increased risk of fractures and falls and osteoporosis and the muscle pain. But we're looking about things like high risk of stroke and heart attacks. That's been in several studies documented. High risk of common things like headaches, for example. Common risk of nausea and abdominal pain and constipation. Common risk of liver cancer. Increased risk of liver cancer. Increased risk of kidney failure, kidney disease. So, the problem, again, when you look at this, you're looking at this over a very long period of time. So that association becomes harder and harder to be precise with as you're looking at the larger periods of time. And of course, because of that, then there's just more controversy and more back and forth because certain studies are going to show very different numbers and researchers will have to consolidate the data from different studies. Often it's done in a mechanism called meta-analysis, which has its own problems because, depending on what studies you included in meta-analysis and which ones you excluded, your data may look completely different. So, and by the way, we're still in a COVID, and yes, PPIs do increase risk of both pneumonia and COVID pneumonia and COVID infection. There's data on that too.
I had never heard that.
Well, now you do.
Mm-hmm.
Which also indicates perhaps a gut immune axis interaction there. Fascinating. One of the things I wanted to talk about is one of the lesser known or less discussed, perhaps, nutritional deficiency that may result from PPIs is magnesium. And magnesium is really important for promoting a state of calm and sleep, both of which are really important for preventing dementia. So it makes me wonder if that may be another mechanism that we should key in, at least for dementia.
As you said so wisely before, it's going to be a multifactorial effect. I have no doubt, and definitely, magnesium is critical for. I mean, was it the 300 pathways in the body? You would know better than me. It's your favorite topic, and and so you can imagine
it's one of those ones that seems to be involved in everything when it comes to nutrition.
Everything, exactly. So you would expect pretty much everything being impacted as a result of it. I think that I had a really interesting case that I often present when I give talks, where I had a patient who came to see me in his 70s, very young looking and very healthy overall, but he started losing strength. He was a long distance runner. He would run half marathons twice a year, and he started kind of gradually not able to run as fast, and then not able to run as long. And the wife has kind of dragged him to see me, and she's like, I don't know, nobody can figure out what's going on with him. His blood pressure is going up, he's getting weaker, he's complaining of occasional aches. And and I'm looking at his pills, and there's blood pressure pills, and there's statins, of course, and then there's PPI. And I'm asking, so how long have you been taking this? And it's like, well, a couple of years I started having acid reflux. And I'm like, so has all this problem started appearing since you started taking this? And I'm like, oh my God, yes. So we took him off the pill. We give him a bit more natural way of dealing with this, which we can talk in a minute. And gradually, when we did the test, he was low in B12 and low in magnesium, both. So we repleted all of that, and give him maybe about 3 months or so, and then his blood pressure improved. He got off the blood pressure pills and started running again. So we often not realizing that the cascade of the side effects often is slow, progressive, and goes from one thing to the next. And because of that, it's often hard to recognize this, especially for people who don't have a holistic provider, people who go from one specialist to another, and the specialist is going to look at a particular area and say, well, I don't see any problem here, right? But you have to look at the whole in order to pick up this kind of discrepancies.
So, Misha, what are some natural alternatives to PPIs?
Right. So, well, first of all, you could basically say, look, why is this happening? So why is this acid reflux happens? And the moment people ask this question, invariably, at least half of everybody gonna realize they're just eating on a go. They're under a lot of stress, and they at the same time they're trying to sort of maintain the diet. The problem is, as we know, in order for us to digest food appropriately, we need to be in what's called a parasympathetic, so in a relaxed state. So when we're eating food and yet we're stressed, the parasympathetic system cannot be effectively activated. So believe it or not, the first and the very important part of the sort of treating most of the common acid reflux conditions is to really say, let's deal with the stress first. Let's have you to do some mindfulness practice. Let's have you eat a bit more mindfully so that you actually pay attention and you chew well. So first line of defense actually has nothing to do with anything integrative. It's really just to say, eat better, eat slower, chew well, make sure you don't eat on the go, make sure you eat when your system is not under tremendous amount of stress. Let's say you just had a fight at work. Well, don't start eating right away. And often people do the reverse. People often would eat when they feel more stress. Often there's this sort of almost like a response, kind of very unhealthy eating in response to stress. So that is the first thing to modify. So then let's say that's taken care of and there's still a problem. Well, then we start potentially using very simple tools. So if there's something, for example, that I love, it's called DGL. I can never say this right. It's basically a licorice that has an active ingredient removed. And when you do that, then you can take pretty much any amount without worrying about blood pressure going up and electrolyte disturbances, and it becomes a coater. So licorice coats the stomach, and then even if the acid does go up, it doesn't really bother the system because there's really this you have somewhat of a different mechanism of action. Very simple, very inexpensive. You can buy a full month supply for $10 or so. So it's very low cost. I actually don't like taking a lot of other acid suppressants or things like Toms, for example. I prefer this kind of natural herbal treatment. So another one is aloe. You can take aloe as a juice, so you can literally just buy it in a food store, or you can take it as a capsule, so you can take it more as an extract, which would be more potent, and you take less dose of it. So those are very, very simple methods. And the licorice, again, called DGL, so just 3 letters. And we'll make sure we'll spell it out, or maybe I'll just Google it right now and I'll tell you. But I always forget because it's a very long name. And that is deglycyrrhizinated licorice. So that active glycyrrhizinate is removed in order for it to be safer, so it doesn't affect the cardiovascular system. So those are my favorite ones. They're not the only ones. There are other methods. Acupuncture can be very effective at lowering acidity and treating all kinds of things, digestive-wise, and many, many other methods. Of course, in a whole systems of care, whether it's Ayurveda, naturopathy, they have a much more complex approach because they do believe that digestion is the most important thing. And so a lot of effort goes into optimizing it, often with just improving a diet. So quite often, Janet started touching on this, right? So quite often acid reflux is a manifestation of other digestive problem, like food allergy or something else. And so you would need to look into that and treat that.
Well, I think those are a lot of good pearls of wisdom, and hopefully people can try those at least first before resorting to PPIs. And if you need the PPIs, you need the PPIs. But these are tools that hopefully will reduce the number of PPIs that either you need to use in your practice or perhaps you need to use yourself. So that is all the time we have for today. Thank you so much for joining us, Misha.
Of course, anytime. Thanks so much.
This is the GW Integrative Medicine podcast from the GW Office of Integrative Medicine and Health.
I'm Dr. Lee Frame.
And I'm Janet Rodriguez. Thanks for listening.
The Office of Integrative Medicine and Health produces the GW Integrative Medicine podcast with funds from your donations. Your generosity allows us to raise awareness of the benefits of integrating whole person care, including evidence-based complementary therapies, into healthcare broadly. Help us continue to grow the podcast by making a tax-deductible donation on our website, smhs.gwu.edu/OIMH. Click the Give Now button on the left. While you're there, sign up for our free monthly newsletter for even more evidence-based content, including free webinars.